Our next speaker, joining us from Penn State University, USA, it's a pleasure to introduce Professor Umar Farooq, who is an academic nephrologist and a physician leader, serving as interim senior vice president and chief medical officer at Penn State Health Milton University Medical Center, and associate professor of certified hypertension specialist. He is passionate about translating innovation into practical, patient-centered care that improves outcome, access, and quality of care. The stage is all yours, sir.
Assalamu alaikum, everyone. Thank you for the kind introduction. It's always heartwarming for me to present in front of my teachers who are sitting as panelists, mentors in the hall, friends in the back. So let's talk about how we reimagine the blood pressure control, really focusing from individualized approach to maybe more some of the population-based strategies and what's new and in the pipeline. So disclosures are important. Some of my, these disclosures are as the principal investigator for some of the clinical trials, the significant or the target BPI, which is a renal denervation trial we completed. There's follow-up arm radiance is in progress. So I'll be presenting, although this particular system is not FDA approved, there are other two which are. Balanced DHF, which is again, I think, a combination of SGLT2 and MRA, trial for heart failure and CKD. I'm also a co-PI for NIH-funded 3D printed soft and stretchable tissue, which you can actually apply on the carotid arteries for baroreceptor stimulation. So yesterday we had our chief guest, Dr. Muhammad Ali. He was the Vice Chancellor of Punjab University. He mentioned about the need of collaboration between the biomedical engineers and the physicians. So this trial is like really a nice 5-year, $2 million grant to develop this. I'm not doing the legwork, so there is a team in or University Park, they are doing it, they just use me as their consultant. So objectives today, I want to cover some of the new therapies which are targeting new targets. So these are the ASIs, aldosterone synthase inhibitors. Again, the RAS system is important, so we need to find new targets, new therapies. Endothelin, which is again another pathway in the smooth muscles for the vascular endothelium. So there are some new drugs developing in the blood pressure on that realm as well. And what about vaccine for blood pressure? Today in the theme of prevention, कोई blood pressure का भी टीका होना चाहिए ना 6 महीने के बाद लगता जाए. So it's another investigational product in phase 2, phase 3 trials. Then we will discuss briefly, cover the device-based. Renal denervation is really getting more and more prominence in US and Europe. So I'll spend some time on that and how we put this everything together with the use of artificial intelligence, remote patient monitoring, and how we switch from individual patient to population based. So imagine if you have to take care of, say, 500,000 population, I want you to challenge and think how you will control that. The targets for the blood pressure, I took this picture from the recent AHA conference. You can see I highlighted the number of societies on top, how more and more societies are aligned with the targets, like 130, ideally below 120. This is how AHA defines blood pressure categories. They are simplifying. So if you want to remember this is normal and elevated, less than 120, 120 to 129. So normal, elevated. In the high, they go to stage 1, stage 2. So normal, elevated, then high, stage 1, stage 2. The urgencies, emergencies, I think they converted into either severe hypertension when it's more than 180 over 120, without symptoms or with symptoms. So when they have symptoms, they need immediate care, but then some of our patients have high blood pressure, you all take care of, even in nephrology and dialysis, they have this chronic, so they don't need to be referred. But this is, to me, it's simpler than previous definitions. Why blood pressure control is important? I think we saw a wonderful presentation from the South Asian population and how the 2 billions, I really love that slide, the 2 billion, 2 billion, 2 billion. So again, I think if you control blood pressure by 5 millimeter of mercury, the relative risk reduction is 10%. And if you bring it down by 10, you bring the risk by 20% down. Now, this is a pooled analysis of 2 separate meta-analysis, and I'm sure others have presented this. But look at the importance of controlling something which is controllable, maybe in your pocket, on your wrist. It's easy to measure. I remember Dr. Azizur Rahman gave a talk, I think, I remember your words. We call it silent killer, but you emphasize that you can just check the blood pressure. It's so easy. You don't need needles. You don't need to go some fancy schmancy, testing cost. It's just like you just need to have a cuff and just make it down on a piece of paper or maybe an AI-generated algorithm these days and control the blood pressure. But when you control it, the benefit is there. So the new drugs, I spent some time on this new target, which is aldosterone synthase inhibition. We all know RAS system is very important. So it's renin, it goes to angiotensin, there's a couple of steps, and then to the aldosterone. So we have ACE inhibitors, we have ARBs. They actually works a little downstream. Even the mineralocorticoid receptor antagonists are also block the effect of aldosterone on the target cell. How about blocking aldosterone upstream? So it's like really a faucet and a drain. So we have been blocking the drain, but the enzyme is there. So can we, control it from upstream? So this one, there are a couple of the drugs. So baxdrostat is one. It's a very selective inhibitor of this enzyme called aldosterone synthase, which is CYP11B2. And you can see some of the steps in the middle cartoon there. The adrenal gland, we all remember, they have different zones. And then how the aldosterone system aldosterone is secreted under the influence of angiotensin and some other influencers. The previous problems were that because the target, any drug development, had cross-reactivity with cortisol, so now we have more selective synthase inhibition. So that is the way the targets is there, but previously we couldn't develop the drug to the to more specificity. Again, longer half-life, and I think this cartoon is probably just a reminder as how renin starts in the kidney. The angiotensin, the pathways like angiotensinogen, and there are some drugs which are also working on the liver production of angiotensinogen, so that will be important for you to consider, and the pathway continues. So you can see that when we have the blockers here, this is another add-on medicine in this whole pathway. So where are we with some of the data about it? So baxdrostat, so there are a couple of trials. The phase 2 trial, again, used for patient with treatment-resistant hypertension. So they checked the doses, 2 milligram, and then the improvement in blood pressure was 11 millimeter of mercury. So then the phase 3 trial, which is for uncontrolled and resistant hypertension, somebody is more than 2 meds or 3 meds, including a diuretic. So there were strict inclusion criteria on that. So 1 milligram, 2 milligram, and placebo. And they saw how the seated blood pressure goes down at 12 weeks. So with 1 milligram, it was 14.5 millimeter of mercury. With 2 milligram dose, it was 15.7. And then there was some, anytime you do these trials, remember when you start to focus on blood pressure, the patient's blood pressure just comes down, not from magic, but because they're so vigilant. This is called placebo effect. But I think placebo effect in this case is very real. So if you placebo corrected, it's like really 8 to 9 millimeter of mercury. Safety issues, again, anything that works on this axis, hyperkalemia is one, so you can see 2 to 4% based on, and it's again dose dependent. So another drug in development, which is lorundrostat, again, a decent blood pressure improvement with the 50 milligram dose was 15 millimeter of mercury. And when they increased the dose, the effect was more or less similar. So placebo adjusted is 5 to 7 millimeter of mercury. And again, hyperkalemia is something that we need to be worried about. So these two drugs are going through some, especially the first one is going through expedited FDA approval. So hopefully we'll have some of this available to us. So what is already available is dual endothelin A ETA receptor antagonist. So this is APRO-C10-TAN. Again, we all know that the endothelin is another pathway. So we have RAS system, we have endothelin system, we even have a neprilysin system as well. Some of those drugs are helping with the blood pressure too. So vascular smooth muscles and endothelium. So when they cause vasoconstriction by contraction of the smooth muscles, if any pathway that can interact there can also help with the blood pressure. So this is the drug. It's a non-RAS and non-aldosterone pathway. So again, something which is working on a different target. So that's why it's helpful and important. And it was approved by FDA in 2024 for resistant hypertension. And then the side effects for this one is fluid retention and edema. So Precision trial was done. That was the basis of approval for this particular drug. So this was the phase 3 trial. They had patients with resistant hypertension, for their definition, more than 140 on more than 3 drugs, including a diuretic. And they used, again, I think there are 3 or 4 phases of the trial. So they had a dose trial, 12.5, 25, and placebo. So there was a 4-week, then there was a 32-week open label, and then they actually had a withdrawal and continued to monitor to see what happens when you stop the drug. So at 4 weeks, the blood pressure reduction was 15 in the lowest dose, 12.5 milligram, and again 15 in the 25 milligram, and even in the placebo there was some improvement. So for this particular drug, I think the placebo-adjusted blood pressure is anywhere between 3 to 5 millimeter of mercury, which we all know that if you bring it 5 down, you get 10% reduction. And these are add-on therapies. These are not usually, by the time you're at the resistance, anything that can bring the blood pressure, say 150 to 140 or 145, that will have a good impact on that. So what about the vaccination I just mentioned, or something you can use every 3 to 6 months? So zilebesiran, now this is investigational yet not approved. It's a long-acting RNA therapy that will really create this interference in the RNA and suppress RAS really upstream of the ACE inhibitors and ARB. So it targets the hepatic production of angiotensinogen that will go to angiotensinogen to the angiotensin 1, to aldosterone and vasoconstriction. So really going above that, and can be given 3 to 6 months. Some of the trials are in progress. So really 10 to 20 millimeter of mercury reduction as well, and this is sustained for months. So imagine somebody who have non-adherence, if you want to control the blood pressure of a population, so if you can inject them, this may be one of the therapy, and the effect is always on. So it's not like daytime, nighttime. So again, this is investigational. Some of the other therapies that we currently use, they are not presented as antihypertensive, but they are actually, they have either even finerenone, we all know that, which is an MRA blocker. Blood pressure hypotension was a side effect. So although it's not labeled to be used for hypertension, but it has those properties, and it makes this sense because there is so much biological plausibility. So the GLP-1s, they are actually coming more and more being discussed as an adjunct add-on blood pressure medication. SGLT2 inhibitor, because of its natural natriuresis, it can cause osmotic diuresis, the volume status is down. So imagine like a patient is on a diuretic. I'm sure all of us, when we are using the SGLT2 inhibitor, if somebody is on higher doses of diuretics, I usually dial the diuretic down a little bit because I'm giving them SGLT2 inhibitor. So this is just like an add-on blood pressure. And the magnitude for GLPs is like 5 to 10. based on several of the trials I mentioned below. And for the SGLT2, maybe slightly lower, 3 to 5 millimeter of mercury. So in the right patient, when you use personalized care, if they have higher BMI, they have diabetes, when you add the GLP, so there you get secondary benefits in terms of the blood pressure, cardiovascular, renal, and similarly the SGLT2 inhibitor. The other drugs are the neprilysin inhibitors, which are used in heart failure. And they also have some properties to improve blood pressure. So when you start somebody on those drugs, make sure that the blood pressure is monitored. But they offer, especially in diastolic heart failure patient as well. So what about device-based? So device-based is really targeting the neurogenic and hemodynamic drivers of resistant hypertension. Let it be at the heart. So there are stimulators at the heart, the top left, so neuromodulation of the heart, or at the carotid, external, or even the internal endovascular therapies as well, or transvenous catheters. There are a couple of devices which are approved by FDA in combination with heart failure, but I can imagine there is a lot of work needs to be done before we will start to see widespread utilization of the beta receptor modulation. What is getting more, I think at the front line is the renal denervation. Why does this work? So imagine kidney as a center. Kidney plays a very central role along with the blood vessels in blood pressure control, and the sympathetic, parasympathetic system, especially the sympathetic system, is part of that. So in the blood vessels, which is the renal arteries, in the blood vessels travel the renal nerves, which are the sympathetic nerves. If you can denervate or block them, you can also have some impact on the RAS system and also blood pressure. So where the renal nerves are really in, the vascular endothelium that is inside, then intima and adventitia. So they are like kind of on the outside, on the vessel wall. And this is how you go endovascularly, similar to when we do the heart catheterization. Go inside the renal artery, try to zap it through radiofrequency ablation or ultrasound, and try to denervate. So these are the three systems. Two of them are already approved. The other one is trying to. So really it delivers, go at the site, deliver the energy. The video is working. I'll play it for maybe a couple of minutes. You can see the catheter goes in, dislodges the actual system, and the energy is delivered. So the vessels, you can see the nerves are traveling in the vessel wall. So vessel is the highway, nerves are the vehicles. So you just block their pathway, cause some fibrosis, block the traffic of sympathetic nervous system, and it has impact on the blood pressure. So just one pooled analysis. So Simplicity, they have a registry. They have over 3 years real world experience, all of these patients in the trial. And office blood pressure reduction at 3 years was consistent, 16 millimeter of mercury, and even on a 24-hour, 10 millimeter of mercury. So it may be equivalent to one drug. So you really have somebody who has either truly resistant hypertension, or they are unable to tolerate. Somebody has allergies, somebody, they don't want to take some of the blood pressure medication. You have the right patient, you exclude their secondary issues, treat them, and then try to maximize the therapy, and then offer them the device trial if needed. Thank you. So the last but not the least is artificial intelligence. And I believe this is an area which is really evolving rapidly. So we have patients who can have either the devices, they could be cuffless, they could be rings, they could be any device. And then we have their baseline data about their bio profile, their labs, their demographics, all that. And when you put all these things in algorithms, you come up with some precise advice to the patient for better risk assessment, for better control. So really you take a lot of input data on you can see in the first column is how you accurately measure the blood pressure from those devices, what are their other baseline characteristics. embed in the EHR, and patients have their portal. And we are actually using this, so I helped one of so we invited a remote patient monitoring, a vendor, and they were building their platform, and we helped them, okay, we can add a nurse navigator or a pharmacist who will take the input and drive some decisions based on an algorithm. But with the AI, that is even making the job easier for us to have really direct interaction from the data. You put in the machine learning, deep learning, and come up with useful blood pressure monitoring, accurate diagnosis, prediction of poor prognostic factors, and improve their overall control. So really that's where, imagine if you have to take care of 500,000 patients, and you have some of the technologies, some of the devices. It's really the iceberg. So you cover your base with the regular drugs. You do better monitoring, some behavior therapy, but as you go up on the iceberg, keep adding these drugs. So really, this is the last slide, and if I summarize, blood pressure is becoming a population. Imagine this is a population-based problem rather than an individual medication problem or individual patient drug devices and digital tools or your add-ons. Be personalized for patients based on their phenotype. Pick a drug that works for them or may work for them. Again, these devices, these are your add-on tools. Please don't forget the basic lifestyle and other therapies which are already there. And continue to work with the teams, personalized care, and use the big data to drive the outcome. So bottom line is, like, it's really it should be personalized for the patient and scalable to population. And I stop here and happy to take, I believe, questions at the end. Thank you.
Thank you so much, Professor Umar, for a fascinating look at how digital tools are reshaping chronic care. With this, we are moving